Good morning, everybody. I call to order this subcommittee's hearing on the Center for Consumer Information Insurance Oversight during the week of the 2-year anniversary of the Patient Protection and Affordable Care Act. My colleagues, it's been 2 years since a health care law was forced on the American people on a purely partisan basis. As we have done since its initial passage, we continue to evaluate the effect the law has on individuals, the healthcare industry, and the United States government. It's fairly obvious what those effects are. Number one, higher cost, higher premiums, and increased government control. Now, these are not partisan points. These are objective facts. Proponents of the law promise lower premiums. They promised lower costs. And they promised that if you didn't want the coverage to change, it would not. That is simply not the case. This month, the Congressional Budget Office announced that the 10-year cost for the bill is nearly $2 trillion, substantially higher than the figure used when the law was passed. The CBO also reported that as many as 20 million Americans could lose their current coverage, despite the President's countless promises that if you liked your coverage, you could keep it. These are not partisan talking points. This is the analysis of the nonpartisan Congressional Budget Office. Meanwhile, the implementation of the law has failed to inspire confidence in the future of Obamacare. The cost and premium increases for some were so large that a waiver program had to be created to excuse over 1,700 companies, insurers, individuals from the law's effect. For example, one business from my home state of Florida needed a waiver so that 34,000 individuals did not face significant premium increases or the loss of their coverage. Yet these waivers still expire in 2014, and I fear the premium increases and loss of coverage will become unavoidable for over 3 million Americans. The early retiree insurance program is practically broke. In fact, we'll probably learn from one of the witnesses today whether this program, which was supposed to last until the year 2014, has finally run out of money. As of last month, it had already spent $4.7 billion of its $5 billion budget. Despite predictions that 375,000 individuals would sign up for the temporary high-risk pools in the first year, only 50,000 have signed up 2 years later. The countless pages of regulations, rules, and requirements for Obamacare have been incredibly confusing. To my constituents and individuals throughout this country, these massive new rules and regulations demonstrate the increasing interference of the federal government into their lives, while to the business community, the uncertainty they create makes planning for the future nearly impossible. Lastly, the creation of the Independent Payment Advisory Board, the IPAB, has been met with universal disdain by the medical community and our seniors. Today we're debating on the House floor a bill to repeal this board of unelected bureaucrats charged with cutting Medicare payments to doctors and to hospitals. Of course, next week the Supreme Court will address the question of whether this unprecedented reach into every American's life is permitted by the Constitution, but today, my colleagues, we want to evaluate the law's effect since its passage. Today's hearing is unique because we will start off with a member panel featuring both Senator Ron Johnson from Wisconsin and our fellow House member Donna Edwards. I welcome both of them this morning. I thank them for appearing and contributing their time. We also have Stephen Larson joining us again today. Mr. Larson is the Deputy Administrator and Director for SACIO and has previously been a witness of both this committee and the Subcommittee on Health. So we welcome him back also for joining us today. And I'd like to recognize the Ranking Member, Mr. Gett.
Thank you very much, Mr. Chairman. I want to welcome our witnesses today. I'm glad to see our favorite friend, Steve Larson, the Director of the Center for Consumer Information and Insurance Oversight. And, of course, we're looking forward to hearing from our colleagues, Senator Ron Johnson and Representative Donna Edwards. Representative Edwards, it's nice to see a woman on a panel here to talk about the women's health provisions of the Affordable Health Care Act. Mr. Chairman, in the spirit of basing today's oversight hearing on the facts, I want to briefly describe some of the benefits of the Affordable Care Act that have or will soon go into effect. Because of this law, 2.5 million young adults who were previously uninsured now have health insurance coverage on their parents' policies. 5.1 million seniors have saved an average of more than $600 each on their prescription drugs through Medicare. More than 30 million seniors and more than 80 million Americans overall now have access to preventative care with no copays, co-insurance, or deductibles. Over 100 million Americans with private insurance no longer have to worry about the worst abuses of the insurance industries. Their coverage cannot be revoked if they get sick, and they no longer have to fear hitting a lifetime coverage limit because of unexpected medical costs. Mr. Chairman, this new health reform law does so much good for so many people, and under the mantra of repeal and replace, all the Republican majority has done is vote to repeal it. Now, we've already had 2 votes in this Congress to repeal the Affordable Care Act in the last year. And yesterday, Representative Ryan introduced his budget, which would not only repeal the health care law, but would decimate Medicare and Medicaid to boot. Mr. Chairman, I'm wondering when we're going to start having hearings on the second part of repeal and replace, which is the replace part of the Affordable Care Act. I want to give you a few examples of how the efforts to repeal but not replace health care reform would hurt women in particular. In July 2011, the prestigious Institutes of Medicine made recommendations regarding preventative health services for women. These experts recommended insurance companies cover the cost of screening for cervical cancer, counseling and screening for sexually transmitted infections, annual well women preventative care visits, screening and counseling for domestic violence, and services for pregnant women. Using authority granted by the Affordable Care Act, the Department of Health and Human Services issued guidelines ensuring the full range of preventative services outlined by the IOM will be covered by health plans and available to all women without co-payments, co-insurance, or deductibles. Mr. Chairman, this preventative care will save women's lives and save money. But the proposal to repeal but not replace the law that makes sure women could get this care has not been answered. That's not all the majority has tried to repeal. Earlier this week, the National Women's Law Center released a report on the pervasive discrimination in the insurance market for women. The report found that the same health insurance policy cost a woman 30, 50, or even 85% more than a man of the same age, even if maternity care is not covered. Mr. Chairman, this is simply wrong, and thanks to the Affordable Care Act, it will not continue. But all I've seen are proposals to repeal and not to replace the law that prevents health insurance discrimination against women. Mr. Chairman, the facts do not support the drive to repeal this bill, but facts don't seem to matter in this case. Republicans have already decided in advance that the law will not work, and the facts have become irrelevant. Let me give you an example. In fact, Mr. Chairman, you talked about it in your opening statement. Last week, the Congressional Budget Office released new Affordable Care Act estimates. Committee Republicans were quick to claim that the CBO's estimates had changed, and this was proof that health care reform had failed. There's only one problem. This is incorrect. Earlier this week, CBO Director Doug Elmendorf spoke out about this misrepresentation, and here's what he had to say. Quote, "Some of the commentary on these reports has suggested that CBO and the Joint Committee on Taxation have changed their estimates of the ACA to a significant degree. That is not our perspective. For health insurance coverage, the latest estimates are quite similar to the estimates re-released when the legislation was being considered. The estimated budgetary impact of the coverage provisions has also changed little." End quote. Mr. Chairman, CBO concluded this year what they concluded 2 years ago when health care reform was passed. The Affordable Care Act will improve health care coverage for hundreds of millions of Americans. It will cover tens of millions of the uninsured. It will improve Medicare, and it will cut the deficit. Millions of Americans are seeing the benefits of health care reform already, and these benefits will continue in the future. Thank you.
Thank my colleague and recognize Dr. Burgess for 2 minutes.
Thank you, Chairman, for the recognition. You know, I've really been interested in this what started life as an agency, the Office of Consumer Information and Insurance Oversight, for a long time. It's always been a little bit of a mystery to me. This is the office that is the lead implementation force, the referee on needed guidance for consumer states and insurance companies on the Affordable Care Act. But nowhere in the Affordable Care Act is there any reference to the Office of Consumer Information and Insurance Oversight. It was a fabrication by the Secretary of Health and Human Services. Now, when the committee began to look into this in November of 2010 and January of 2011, the agency morphed into the Center for Consumer Information and Insurance Oversight and was drawn back into the Center for Medicare and Medicaid Services. And it's been tough to get information out of this agency. Yeah, sometimes it has come, but it's come in small morsels, and it's required an inordinate amount of staff time in order to get the budgetary information, and by the time we receive it, it's frequently months out of date. Well, the operations of the Office of Consumer, or the Center for Consumer Information and Insurance Oversight, are now under the aegis of the Center for Medicare and Medicaid Services. This is the most powerful health agency on earth, and indeed that the earth has ever known, certainly within the federal government, because they have under their control now Medicare, Medicaid, S-CHIP, and for the first time, with the passage of the Affordable Care Act 2 years ago, private insurance is now regulated by the federal government in the Office of Consumer Information and Insurance Oversight. So it is essential that we as an oversight body maintain the oversight over this, now this very large and crucial organization. We got a Supreme Court hearing going on, a Supreme Court case being heard next week. It'll be very interesting to know what the contingency plans are at HHS and SOCIO should the Supreme Court not rule the administration's way. I'll yield back the balance of my time.
Gentleman yields back. Gentleman from Tennessee is recognized for 1 minute.
Thank you, Mr. Chairman. I want to welcome our guest, Senator Johnson. Great article in the Wall Street Journal today on Obamacare. We appreciate the work you've done, Ms. Edwards. We're so pleased that you are with us, and Mr. Larson, want to welcome you back. As we look at what has happened over the past 2 years, we see that $500 billion has come out of Medicare. Our constituents are aware of this. They are concerned, and they look at the cost of this entire bill. Now, as the chairman said, what we have found out is that the cost has doubled since the original estimates. Those of us from Tennessee who had TennCare, the test case for Hillary Care back in '94, indeed reported repeatedly that the cost quadrupled within 5 years. So we're going to want to look at what is happening with this cost. We are concerned about it. We're concerned about the potential loss of coverage from 5 to 20 million Americans. We hear from a lot of our constituents about the escalation in cost of their private insurance premiums, and indeed many of my constituents, female business owners, talk about their concern about loss of coverage and access to consistent coverage for elderly relatives, for children with chronic conditions, because they see this insurance market changing, and they know that the changes that are in front of them are not going to help them with consistent health care, and we express those concerns, and I yield back the balance of the time.
The lady's time has expired, and the gentleman from Louisiana is recognized for 1 minute.
Thank you, Mr. Chairman. Appreciate you having this hearing. I want to thank our panelists who are going to be testifying later. And, I think it's important as we approach the 2-year anniversary of the President's health care law that we look back and see just what has happened, what it's doing to the health care marketplace, and in fact, if many of the promises that were made have been kept or broken. And I think what we've seen so far, I know as I've talked to small businesses throughout my district, the biggest complaint that they give when they talk about the things that are keeping them from hiring people right now, keeping them from creating jobs, is the President's health care law. The cost that it's added, the uncertainty that it's added. If you look at what it's done to Medicare, $500 billion was raided from Medicare by the President's law, and in fact the President's own health care actuaries confirmed that Medicare will go bankrupt in less than 12 years, and this is the current law of the land. And so absolutely we want to repeal it, get rid of the higher costs, get rid of the broken promises and the lost health care and the crony capitalism, as we'll see from these waivers that have been issued by many friends and supporters of the law, whereas regular hard-working taxpayers, small businesses weren't able to get those same waivers. I think it's important that we look back on all of that and and hopefully work to address the problems, like we will be working to repeal this unelected board of 15 bureaucrats that would have the ability to ration care. So thanks again for having this hearing, and look forward to our panel. Yield back.
I thank the gentleman. The chair recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Mr. Chairman, as we approach the two-year anniversary of the Affordable Care Act, we have an opportunity to highlight the tremendous benefits that this landmark law has and will provide for millions of Americans. And I'm pleased to welcome our two first witnesses, Senator Johnson and Representative Edwards, and I know we'll be hearing from Steve Larson from the CCIO, who will be implementing a lot of the legislation. But House Republicans seem determined to overturn this law, regardless of the facts. And I find it hard to understand. The Affordable Care Act is giving vital benefits for millions of Americans. We are living up to the promises of this law. Nationwide, the law has provided insurance coverage for over 2 million young adults who were previously uninsured, saves over 5 million seniors an average of more than $600 each on their prescription drugs, provided more than 30 million seniors, more than 10 million children, and more than 40 million adults new access to preventive care with no copays, coinsurance, or deductibles. Thanks to the Affordable Care Act, over 100 million Americans no longer have to worry about their coverage being revoked if they get sick, or about hitting a lifetime coverage limit because of unexpected medical costs. Last week, my staff prepared reports on the benefits of the Affordable Care Act in all 435 congressional districts. Mr. Chairman, I'd like to enter the reports for the 23 members of the subcommittee into the hearing record.
Will do. I don't think
They show that health reform is helping hundreds of thousands of people in each of our districts. In my district, health reform has provided 8,600 young adults with health coverage and given 9,600 seniors an average discount of $700 per person on their prescription drugs under Medicare Part D. And Mr. Chairman, in your district, because of health reform, 113,000 seniors have received Medicare preventive services without paying copays, coinsurance, or deductibles. Up to 42,000 children with pre-existing health conditions can no longer be denied coverage by health insurers, and 250,000 of your constituents no longer have to worry about lifetime coverage limits on their health plan. And in the months and years to come, even more critical benefits and protections will go into effect. Later this year, every health insurance policy sold in this country will begin providing consumers with a clear, consistent summary of the costs and benefits of their coverage, like food nutrition labels for health care plans. In 2014, when the law is fully implemented, plans in the private market will be sold in transparent and competitive exchanges where consumers can be sure that the plans they purchase will be there for them when they need them, without annual or lifetime limits, regardless of a pre-existing condition, without insurers making unjustifiable premium increases or wasting huge percentages of premium dollars on administrative costs and profits. These are the facts. They show the Affordable Care Act is working and will continue to benefit the American people. What won't work is a Republican alternative. They want to repeal the law. They said, we'll repeal and replace. Now we know what their replacement is. From the Budget Committee chairman yesterday, the proposal is it would repeal health care reform, decimate Medicaid, cutting over $800 billion from this critical safety net program, and it would slash hundreds of billions of dollars from Medicare. after all the money that people complain about that was taken from the Medicare overpayments in the insurance, some of the insurance companies, the Republicans would leave that in place, and then they cut another additional hundreds of billions of dollars as well, ending the program's basic health guarantee for seniors. Mr. Chairman, these Republican solutions are wrong. They would devastate Medicare and Medicaid, leave tens of millions of Americans without health insurance at all. Their way of holding down costs is to shift those costs onto the Medicare individuals. And for the states, they'd tell the states, here's less money for Medicaid. You can cut back on health care for disabled people and very, very poor people under Medicaid, while we're going to make sure that we're going to give wealthier Americans further tax breaks. I think that's obscene, and I think the American people will see through this Republican effort.
Gentleman's time has expired. We'll now go to our witnesses. Our first panel, of course, is Senator Rod Johnson from Wisconsin and Congresswoman Donna Edwards from Maryland. We welcome both of you today, and Senator Johnson will recognize you for 5 minutes.
Thank you. And good morning, Chairman Stearns, Ranking Member DeGette, members of the committee. Thank you for the opportunity to participate in today's hearing on the Patient Protection and Affordable Care Act. Unfortunately, this Orwellian-named law will neither protect patients nor make health care more affordable. It is my current mission to paint a picture of what America's health care system, our freedoms, and our federal budget will look like in the unfortunate event that Obamacare is fully implemented. It will not be a pretty picture. Nancy Pelosi famously stated that we had to pass this bill so you can find out what's in it. I am determined to make sure we don't have to fully implement it to see what it will cost. 28 years ago, our infant daughter, like millions of other Americans, was saved by our health care system and medical professionals that dedicate their lives to saving the lives of others. Today, our daughter is a nurse herself, helping to save infants in a neonatal intensive care unit. These are the people that President Obama chose to demonize in his quest to take over 1/6 of our economy. The result of his efforts was an ill-conceived, totally partisan, 2,700-page bill whose benefits were wildly overstated and whose costs will prove to be dangerously understated. And let me start there. Understated costs. To sell the fiction that Obamacare would provide health care to 25 million uninsured Americans without adding one dime to our deficit, the original budget window included 10 years of revenue and fictional cost savings totaling $1.1 trillion to pay for only 6 years of benefits totaling $938 billion. Increased taxes, fees, and penalties account for roughly half of the $1.1 trillion pay for. The other half supposedly results primarily from reduced payments to Medicare providers and cuts in Medicare Advantage. But Congress has not allowed the enactment of the $208 billion provider payment cuts required under the sustainable growth rate formula because it understands those cuts would dramatically reduce seniors' access to care. For the same reason, how likely is it that Obamacare's Medicare reductions will actually occur? In addition, how likely is it that on net, only 1 million out of the 154 million Americans that have employer-sponsored health insurance will lose that coverage and be forced to obtain coverage through the exchanges? Not very. Yet that was the CBO estimate that helped produce Obamacare's unrealistic deficit reduction score. Instead of trying to interpret and comply with over 15,000 pages of rules and regulations, and instead of paying $20,000 in 2016 for family coverage, why wouldn't business owners simply pay the $2,000 penalty? And by dropping coverage under Obamacare, they wouldn't be exposing their employees to financial risk. They would be making them eligible for huge subsidies in the exchanges, $10,000 if their household income is $64,000. A recent study by McKinsey & Company found that 30 to 50%, that would be 48 to 80 million Americans, but 30 to 50% of employers plan to do just that, drop coverage. CBO's March 2012 baseline estimates 9-year Obamacare Obamacare outlays will exceed $1.9 trillion. Adding that many individuals to the exchanges could add trillions to these projections. Can America afford to take that risk? Those trillions of dollars for Obamacare will be taken from hardworking American taxpayers and the private sector, filtered through the federal government in order for Washington to dictate the terms of health care consumption and delivery to every American. If that happens, we will be ceding a significant portion of our personal freedoms for the false promise of economic and health care security. There are too many uncertainties, and the stakes are far too high to proceed with implementing Obamacare. It is time to put the brakes on until we fully understand all its costs and consequences. In closing, let me ask some questions the administration should answer before Obamacare is fully implemented, and it really is too late. If the Medicare cuts actually are enacted, how many doctors will stop taking Medicare patients? What services will be cut? How will quality suffer? Isn't this how rationing begins? Because Medicaid reimbursement rates are often lower than provider costs, approximately 40% of providers do not accept Medicaid patients. How will the remaining 60% handle the 25 million new Medicaid beneficiaries? Faith in the federal government is appropriately at an all-time low. How many Americans actually believe Washington can effectively and efficiently take over 1/6 of our economy? Does anyone think government would have invented the iPhone or iPad? What will happen to medical innovation under government control? Will Americans like federal bureaucrats telling them they cannot get mammograms until they reach the age of 50? Or the Independent Payment Advisory Board becoming Medicare's de facto rationing panel? Defensive medicine and junk lawsuits cost Americans hundreds of billions of dollars each year. Why was malpractice reform rejected? Did it have anything to do with President Obama's support from trial lawyers? Why would anyone think increasing taxes on health insurance plans, medical devices, and drugs would help bend the cost curve down? The actual result? Instead of lowering the cost of a family insurance plan by $2,500 per year, as President Obama promised, family plans are now $2,200 higher. Does anyone really think that on net, only 1 million Americans will lose their employer-sponsored care and be forced into the exchanges? And finally, why have 1,722 waivers covering 4 million Americans been granted if implementing Obamacare doesn't threaten current health insurance plans? President Obama promised if you like your health care plan, you will be able to keep your health care plan, period. No one will take it away, no matter what. I'm not sure what you'd call that statement, but whatever you call it, it was a doozy. Thank you, Mr. Chairman.
Thank you, Senator. We recognize the gentlelady from Maryland for 5 minutes.
Thank you, Mr. Chairman and Ranking Member DeGette, and thanks for holding this important and timely hearing on the nation's healthcare system and for the opportunity to be here to testify today. I represent Montgomery and Prince George's County, right outside of Washington, D.C. Even in my congressional district, close to the nation's capital, there are thousands of people who go without health care every day. I was honored to preside over the passage of the Affordable Care Act in the House and filled with pride, actually, to witness President Obama sign the landmark bill into law. Although the health care reform law has faced some opposition from some, I'm proud and steadfast in my support of the Affordable Care Act and the preventive care, the primary care, the community-based care, and the quality care that will now be received by millions of Americans. Before the enactment of the Affordable Care Act, our healthcare system had been failing a large part of our population who most needed insurance coverage. In a national survey, 12.6 million non-elderly adults, 36% of whom tried to purchase health insurance directly from an insurance company in the individual market, had been discriminated against because of a pre-existing condition just in the last 3 years. With a federal high-risk pool, these Americans will have access to a critical program that provides life-saving health care coverage. And the Affordable Care Act also encourages and enables people to seek out care sooner, saving the system money and increasing the chance of positive outcomes, health outcomes in the long run. That we should look to as very encouraging. I worked with my colleagues, and I was interested to hear you, Mr. Chairman, particularly Jen Schakowsky, in championing a provision that holds insurance companies accountable for excessive premium increases. That ensures affordability for working families who have health care coverage, but for whom costs are skyrocketing. In my congressional district, the provision has already helped protect 190,000 residents from price gouging by requiring health insurers to post and justify the increases of 10% or more. This is true all across the country in every single congressional district. At this important 2-year anniversary for constituents in my district and throughout the country, health reform has already delivered important and tangible benefits due to a number of provisions in effect today. I'm proud that our system would allow me the option to keep on my health insurance policy my 23-year-old up until age 26 in the event that he doesn't receive coverage through an employer. I visit senior centers regularly, where seniors now understand that the Affordable Care Act strengthens their Medicare benefits by closing the prescription drug donut hole and expanding coverage, all while lowering costs to them. Under the expanded benefits of Medicare, seniors can receive annual physical and preventive screenings. And the small businesses in my district and all across this country have received the benefit of a 35% enhanced to 50% tax credit in 2014 to help them as employers cover the cost of premiums paid to insure their workers. And with the filing deadlines approaching, employers should look for that credit on their return. And for women, and I am proud that for women all across this country, the Affordable Health Care Act has had a remarkable impact on their ability to finally obtain affordable and comprehensive coverage. According to the Commonwealth Fund, when the law is fully implemented, nearly all the 27 million women in this country, ages 19 to 64, who were uninsured in 2010, will gain health care coverage that meets their needs at a fair price. By 2014, health care reform will keep insurance companies from denying women coverage due to pre-existing conditions, like experiencing domestic violence or pregnancy or even acne. What a shame that we needed a law to ensure that insurance companies would not penalize women for those or other conditions. But you know what? I'm happy we have that law to do exactly that. And further, as members of this panel, male and female, know the act of choosing a doctor for your health needs an important and a personal decision. It is an important and personal decision. The Affordable Care Act ensures that women are able to choose any doctor they trust without a referral. As if insurance companies didn't have enough influence over the health care decisions of women before the passage of the Affordable Care Act, insurers could also choose to charge a woman more for her insurance policy just because of her gender. The National Women's Law Center reports the practice of charging women more than men for the same coverage costs women $1 billion a year with little evidence to explain the difference. And now, with the Affordable Care Act in place and scientific findings of the Institutes of Medicine, women will receive a full range of preventive services at no cost, including mammograms, colonoscopies, Pap tests, as well as well-woman visits, HPV testing, contraceptive methods, and support for interpersonal and domestic violence. To date, 20 million women have accessed these free preventive services. And for minority women like me, who too often go uninsured, the Affordable Care Act will provide equal access to health care and close health disparity gaps that plague women in underserved communities. And so I appreciate the opportunity to be here today to celebrate the good news of health care delivery for the American people through the Affordable Care Act. And I thank you. And I'm happy to answer any questions.
I thank both of you. Senator Johnson, do you have time to answer any questions?
I believe so. I'll run out of here at the last minute.
Okay, because I saw that you might have a vote here in the Senate. I guess a question for you would be, what experiences in the private sector?
Those health care purchasing decisions moving forward. And certainly the passage of Obamacare changes the equation entirely. I mean, put yourself in the position of a business owner trying to comply with currently 15,000 pages, and that's just simply going to grow. And then take a look at the cost equation. So we've totally changed the equation in terms of how we're going to buy health care. But the other experience, life experience, was pretty significant, was the birth of our first child. Our daughter, Carrie, who was born with a very serious congenital heart defect, her aorta and pulmonary artery were reversed. So the first day of life, she was rushed down where one of those greedy doctors came in at 1:30 in the morning and saved her life. And then 8 months later, when her heart was the size of a small plum, some other incredibly dedicated medical professionals reconstructed the upper chamber of her heart. So her heart operates backwards right now. But she's a nurse herself, and she's a 28-year-old woman practicing medicine because my wife and I had the freedom, again, just with ordinary insurance coverage. This is no Cadillac plan. We had the freedom to seek out the most advanced surgical technique at the time, which allowed Carrie to have such a wonderful result. So no, I've got very direct experience both in terms of buying health care as well as being on the consumption side of that in a wonderful story that has a very happy ending.
Senator, I also had a small business myself and understand the complexities. Do you think if this is the health care put in place, do you think employers will sort of dump employees all into the exchanges? What's your estimation of what will happen there?
Well, that is a current concern, and the CBO initially estimated only 1 million people would, but there have been surveys. The McKinsey one is the one I quoted that said 30 to 50% of employers, and by the way, that percentage goes up the more they know about the health care law, plan to do just that. Now, will they actually do it? Nobody knows. But what we're trying to get the CBO to do is let's give us the information just in case. I mean, what if half of the people that get their insurance through employer-sponsored plans actually lose it and access the exchanges under very high levels of subsidy? That'd be 75 to 80 million people, and then, of course, that would result in cost shifting, putting more pressure on premium rates, which would cause even more employees to lose their health care coverage. And quite frankly, Chairman, I think that's exactly the way this health care law was designed. It was designed to lead to a government takeover of the health care system, basically a single-payer system.
Congresswoman Edwards, you heard the opening statement of Ms. DeGette in which she talked about the Medicare, and I think either she or Mr. Waxman talked about Medicare and how the Paul Ryan budget would impact Medicare. Are you concerned, I think like a lot of us are, that when we passed Obamacare, there was a cut of $500 billion from Medicare? Does that concern you at all, that these cuts are, one, feasible, or are they accounting gimmicks, or will it ever happen, I guess?
Well, thank you, Mr. Chairman, for the question. But let's look at the facts. In fact, what has happened is that we're actually saving seniors and providing additional benefits with the savings that have been achieved in Medicare, because after all, that went back into the Medicare system. And so when I look at our seniors, for example, who receive who are working up to that donut hole, and that they now can actually receive a benefit that they wouldn't by closing the donut hole. Those are benefits. When I look at seniors who now can go for an annual physical so that they can look down the line to avoid illnesses or conditions that might otherwise impact them negatively, those seniors are actually receiving benefits through the savings that we actually achieved in Medicare. And so I think the American people should actually have the facts straight in terms of what we did with Medicare. And what we did was enhanced benefits for Medicare recipients so that we can ensure the coverage of preventive care, close the donut hole, and make sure that we have a system where we're able to enforce fraud as well.
I would say, in defense of what you said, is what you're talking about, paying for subsidies, but the $500 billion is actually impacting Medicare, and this is something good that the second panel can bring out, because most of us feel the $500 billion will have a huge impact on Medicare, and that's going to go to what I think Senator Johnson talked about. A lot of these doctors and others are just going to not want to take Medicare. With that, I recognize the ranking member.
Thank you very much, Mr. Chairman. Senator, thank you for coming over, slumming it with us here in the House. When you talked about your young daughter who had the heart surgery, it struck a chord with me, because I have a daughter who was diagnosed with type 1 diabetes at age 4 when I was in my first term in Congress. And I lived like you did, with the uncertainty of a chronically ill child who would be ill for her whole life. And I was terrified for many, many years about the idea that when she turned 18 or when she graduated from college, she might be uninsurable. And in fact, my husband and I actually went to see our attorney about trying to set up some kind of a fund from our earnings. Forget about college. We were worried, could she afford to pay for her diabetes care? And there's 17 million children in this country who have pre-existing conditions like your daughter and my daughter, who now will be guaranteed that they'll have insurance. I would imagine, I know that you're against the Affordable Care Act, and I know that you'd like to repeal it, but I would imagine you would think it would be a good thing if insurance companies couldn't simply drop kids because they had pre-existing conditions.
Well, first of all, there's a far simpler solution. We didn't need a 2,700-page bill. We didn't need another 12,000.
What is that solution?
So the solution is what many states have. Almost most states have high-risk pools, and they work very well. And the way they work is every insurance carrier that's licensed in the state has to participate in those pools. And it's a known risk. It's actually pooling the risk. That's what insurance is all about. So that when people are uninsurable, they become eligible for those high-risk pools, and those insurance rates are subsidized. Again, we're a very compassionate society here, and we want to provide a strong social safety net. So we're certainly in support of that, but we didn't need to pass a 2,700-page bill and a virtual national takeover, federal takeover of our healthcare system to accomplish that goal.
So in Wisconsin, for example, under the Affordable Care Act, there's 95,000 kids that would be in that situation. Does Wisconsin have a high-risk pool?
Yes, it does.
And were all of those kids covered in the high-risk pool?
That I couldn't say. Am I saying the high-risk pools are perfect? No. But we could have made adjustments to those on a state-by-state basis as opposed to a total federal government solution.
Okay, and do you have any idea how much it would cost, say, in Wisconsin or Colorado to insure 95,000 kids that weren't already insured in those high-risk pools?
I don't have those exact figures, but I have, in my previous life as a business owner, I've looked at the insurance rates for the high-risk pool in Wisconsin. They were very comparable to the same rates we were paying on an annual basis in our business with our business plan. They were very comparable.
And does every state have a high-risk pool like that?
I'm not sure not every state, but the vast majority do.
And see, the question I'm asking is, all of these 17 million kids who are now can't be discriminated against, these are kids who previously were not insured in the high-risk pool. So I'm just wondering if you or your staff have done the math to figure out how much extra it would cost in the states to give those subsidies. Because I don't know about your state, but in my state, we're having difficulty keeping our police officers and our firefighters and our teachers on the payroll.
Let me just answer by saying I'd like to dispel a notion, because I hear it over and over again that now seniors are obtaining preventative services for free, and we're offering coverage to children up to the age of 26 for free. Nothing is free. We're just spreading the risks. And I would say when we spread it and we filter it through the federal government, which, by the way, there aren't too many Americans that think that the federal government is capable of taking over 1/6 of our economy to do it effectively and efficiently. I think going through a federal government is the least efficient way of pooling those risks and taking care of those individuals.
Okay, I hear what you're saying. I disagree, but I hear what you're saying. Now, Congresswoman Edwards, I just wanted to ask you a question. The chairman asked you about Medicare cuts under the Affordable Care Act. Have you glanced at the new Ryan budget that was introduced yesterday?
Well, it's very disturbing, actually, because I think that what the new majority budget does is it actually undercuts Medicare. I mean, we would, in effect, be saying to our seniors, not only are we going to get rid of the program that you've known and that you trust and that delivers efficient care, we'd be saying to you, we're going to ask you to reach into your pocket for thousands of dollars that we know that you don't have in order to, I don't know, it looks to me as though it would be turning Medicare into a private kind of system where individual seniors would be kind of out on the marketplace in order to obtain their health care. I don't think that that's the system that the American people want, and I think for the seniors that I visit in my congressional district, and I would imagine that this is true across the country, that those seniors right now must be wondering what it is that we're thinking here on Capitol Hill, that we would take a system that is working, that is providing a benefit that they too have paid into, and ripping that out from under them.
Thank you very much.
Gentlelady's time has expired. Anyone, Senator Johnson has to leave in about 5 minutes or less. Anyone on my side would like to ask a question? Dr. Burgess?
I thank the Chairman for yielding. Senator Johnson, this is something with which I worked with the previous ranking member on the Health Subcommittee, Nathan Deal, who's now the governor of Georgia, on the pre-existing condition issue. And I think you're exactly right. In fact, when Senator McCain was running for president, one of the difficulties he had was he articulated a very detailed plan on health care as opposed to an amorphous plan, but the detailed plan that Senator McCain talked about, in fact, built on the very structure that you talked about, the already existing state risk pools, state reinsurance programs, and I think there were a couple of other novel ways that states dealt with this. In Texas, I'm a physician. I practiced for a long time. I can't tell you that I ever saw anyone who was covered under one of the risk pools, but I understand since entering into this discussion over the last several years that there are many people in Texas who are covered and do not want to see that coverage changed in any way whatsoever. I can promise you I never got a reimbursement check from state high-risk pool as a physician, but at the same time, I think there is ample evidence that they do work. The problem is that the state has limited the amount of subsidy that they can provide. So if we were going to build something, it would have made a lot more sense to build on those 35 state programs that already existed. Now, Nathan Deal was very sensitive, not wanting to create a new state mandate, but he suggested that a federal subsidy could be available to a state that was willing to provide such coverage and make it an incentive rather than a punishment. Those bills were introduced in the 111th Congress, H.R. 4019, 4020 for anyone who's keeping score at home. Those things are ready to go as part of any replacement strategy if something happens to the Affordable Care Act, like the Supreme Court voids its existence at the end of June when they provide us with their ruling. So I just wanted to emphasize, I think you're right on the mark. We'll hear from Mr. Larson about the high-risk pools and the success they've had, but we were led to believe when this debate was going on, and I don't believe you were in the Senate when the debate was going on, but we were led to believe through the popular media and through discussions with the President that this number was 5 million people, 8 million people, 15 million people who were not covered with because of pre-existing conditions, 50,000 people in the first 2 years of this new federal subsidy that was set up, and how much more could have been done had a program been designed that would have helped the states do what they were doing already. In other words, augmented the help that they were providing. And for the life of me, I have never understood why we took upon ourselves to set up a brand new federal program, a brand new federal agency, all new computers, all new staplers, and didn't utilize the structure that was already there in your state and my state and 35 other states across the country. Do you have any thoughts on that?
Yeah, and before I go, I'll make 2 points. First of all, as I recall, and I wasn't here at the point in time, but it was very difficult to get people signed up for the federal program, and initially, with the initially set premiums, only a couple thousand people signed up, so they had to drastically reduce the premium rate to even get the 50,000, which is way under the estimate. I also want to just dispel the notion that Republicans don't have solutions. We have plenty of solutions. You know, why don't we reform our malpractice and save hundreds of billions in defensive medicine? And finally, dispel the notion that Medicare and federal government doesn't deny benefits. They actually deny benefits at almost twice the rate of large employers, at about a 4% rate versus a little under 4% versus about a 2% rate for most large insurance companies. So again, there is an awful lot of misinformation. And with that, Mr. Chairman, again, I appreciate it, and I'm going to have to go take a vote.
Senator Johnson, thank you very much for taking your time to come over to the Senate. And,
let me reserve the balance of my time. We'll let the senator leave, but I just want to make one other point on the pre-existing conditions for kids. There was a drafting error in the Affordable Care Act as it was passed by the House and Senate and signed. Indeed, the Affordable Care Act said that insurance companies could not limit coverage for kids, but there was nothing that prevented them from denying coverage to children. So the actual loophole that would have allowed insurance companies to get out from under covering pre-existing conditions for children still existed at the signing of the Affordable Care Act. And because most of the insurance companies said, hey, look, we understand it was a drafting error, we will do the right thing and not deny coverage to those children. In fact, that's what allowed the Affordable Care Act to work, but it was just one more example of the numerous drafting errors that were contained in this thing. And the reason there were drafting errors was because it was rushed through, it was force-fed through the Congress and force-fed on the American people, which is why it has never enjoyed immense popularity. And we're going to get into more of that as this goes on. I'll yield back.
all right. We would thank the gentlelady from Maryland for attending. With Senator Johnson leaving, you are also can leave, and we'll go on to our second panel. Thank you. I would say just a comment to my colleague from Texas that it would be nice to see on the Democrat side their plan to save Medicare. Congressman Paul Ryan has come up with a plan to save Medicare. It would be awfully nice to hear either the President or the Democrats provide us a plan. With that, I'll have the second panel is welcome. We have just one witness, my colleagues, Mr. Steve Larson, the Director of the Center for Consumer Information Insurance Oversight. Mr. Larson, I think you're aware that the committee is holding an investigative hearing, and when doing so has had the practice of taking testimony under oath. Do you have any objection to taking testimony under oath? Any objection to taking? Okay. The chair then advises you that under the rules of the House and the rules of the committee, you're entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony this morning? In that case, you please rise and raise your right hand. Do you swear the testimony that you're about to give is the whole truth and nothing but the truth, so help you God? You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. We welcome your 5-minute summary of your written statement.
Chairman Stearns, Ranking Member DeGette, members of the subcommittee, thank you for the opportunity today to highlight the efforts of CMS and my office, CISO, in implementing the provisions of the Affordable Care Act. Over the last 2 years, we've been focusing on implementing the ACA as smoothly as possible in a way that continues to strengthen the productive partnership between the private sector and our office and the government. I'd like to highlight some of the very important provisions of the ACA and the benefits that they provided to millions of Americans already. For example, in the past, young adults making the transition from school to work have been more likely than any other group to go without health insurance. The ACA makes it easier for younger Americans to get health insurance coverage because the law allows young adults to be covered under their parents' policies up through the age of 26. And about 2.5 million young adults have already gained health insurance coverage because of this part of the law. In addition to helping young people find health insurance coverage, CMS established the Pre-Existing Condition Insurance Program, or PSIP, which we've talked about. It was created under the ACA, and it provides an affordable coverage option for uninsured people with pre-existing conditions until the broader reforms of the ACA take effect in 2014. Already, PSIP is helping 50,000 Americans with pre-existing medical conditions to access critical health care services. Many of these individuals have been diagnosed with cancer and other life-threatening diseases, and without PSIP would have no other coverage options. Besides ensuring that people have access to private health insurance coverage, CMS is working to implement new rights and benefits for consumers. For example, insurance companies can no longer drop or rescind someone's policy simply because they made an unintentional mistake on their application. Insurance companies can't place lifetime limits on the dollar value of the benefits in the policy. Before, cancer patients and individuals with serious and chronic and expensive diseases often had limited treatment or went without treatment because they had reached their insurer's lifetime dollar limits on their health insurance coverage. Now, with this provision in place, about 105 million Americans, including nearly 28 million children, enjoy better coverage without the worry of bumping up against lifetime dollar limits. Also, about 54 million Americans in new insurance plans are receiving expanded coverage for recommended preventive services without additional out-of-pocket payments, including colonoscopy screenings for cancer, pap smears and mammograms for women, well child visits, flu shots, and other preventive services. The ACA also increases transparency for consumers. Starting this September, health insurers and group health plans will have to provide clear information about health plan benefits and coverage in a consistent, easily understandable format that allows apples-to-apples comparisons. The ACA also helps make sure people get value for their insurance premiums. For example, the rate review program does this by making sure that proposed rate increases that exceed 10% in the small group and individual market are reviewed by experts in order to make sure that they're reasonable. And rate review is primarily a state-based reform, with the majority of the states, not HHS, conducting these reviews. The medical loss ratio provision makes sure that people get value for their premiums by requiring that insurance companies spend 80 or 85% of the premium revenue for medical care and to improve the health care quality for their customers. We know many insurers are moderating their rates in order to meet the MLR standard already. We've worked steadily towards establishing the affordable insurance exchanges. We have issued extensive guidance to states and other stakeholders over the last 2 years in many areas related to exchanges. And earlier this month, we released the final rules on exchanges that provide flexibility to states to build exchanges that work for them in their state. And we know that states are making good progress toward establishing their own exchanges. CMS is proud of all that we've accomplished in the last 2 years, and I look forward to partnering with Congress, the states, consumers, businesses, and other stakeholders across the country to strengthen insurance. Thank you for the opportunity to discuss the work that CMS and SOCIO has been doing to implement the ACA.
Mr. Larson, thank you very much. I'll start with my questions. You know, the main point of contention is the mandate, and of course, the Supreme Court will be looking at that shortly. So if you can just answer the question yes or no. Is your office going to be responsible for enforcing the mandate, yes or no?
Well, in conjunction with our colleagues at the Department of Treasury and the IRS.
So will you have the main responsibility in your office for enforcing the mandate?
Well, the individual responsibility provisions ultimately are enforced through the tax code, so it's largely IRS and Treasury.
But have you worked out any provisions in terms of a narrative on how you're going to enforce the mandate in your office?
Not yet, no.
Not yet. And since you run the exchange, how will you determine if an individual has purchased health care or not?
Well, that's one of the issues that we're working through now is the data that we collect through the exchanges and through employers to know who has coverage and who doesn't. And again, that's
Will this data be precise? You'll be able to tell if a person has a health care or not?
Yes.
And how will you determine that?
Well, it will involve getting information from both employees and individuals. And
Is this going to be voluntary?
And from employers to provide the information.
Will this be voluntary to the employees and to the employer?
Well,
yes or no?
the employees and individuals will want to provide the information so that they can know that we know that they have health insurance coverage, and employers will want to give the information so that they know that they're...
So you're saying it's all voluntary?
Well, I'm not sure quite how to answer that because obviously there are...
I think it's not voluntary. I think the answer is
well, there are
not
financial
voluntary.
provisions that apply.
It's called a mandate.
People can choose
Let me
not
ask
to
you,
buy the
what kind of
insurance
manpower is going to be required in your office to enforce this mandate?
That I don't know yet.
So you have no idea whether you're going to increase the number of people?
Well, we have plans to increase our staff in connection with the areas that we're enforcing. I don't know what the plans are with respect to IRS.
Okay. When does enrollment in the exchanges begin?
Well, the exchanges have to be up and running in January of 2014, and so there'll be an open enrollment period preceding that in October of 2013.
What rulemaking have you issued with regard to these exchanges?
We've issued a number of rules, both final rules, proposed rules, and then guidance to the states on a range of topics. As I mentioned, we did just release the final exchange rule. There's a rule that we call the 3 R's rule that is for reinsurance, risk adjustment, and risk corridors, which are financial mechanisms to stabilize the market in 2014. So that final rule was issued. There were final rules on the Medicaid provisions that relate to exchanges as well. And there's been a number of papers and bulletins that we've released on topics such as
Sounds a little
actuarial
complicated.
value. Well, it's not complicated, but there's a lot of work to do to get ready for 2014.
When can we expect the rules on essential health benefits and actuarial value to be released?
Hopefully soon. We're working on that. We released initial guidance to the states back in December, and we've issued additional guidance after that in the form of questions and answers. And we know states and issuers are anxious to get that information. So hopefully in the near future.
Have you conducted any analysis of the effect on family or individual premiums?
We have not conducted an analysis of that at this point.
Who's going to do that, or when is it going to be done?
Well, we will be doing that. I know CBO has looked at that. A number of private entities have looked at potential rate impact. States have looked at that. It does vary
Wouldn't this
significantly.
affect some of the decisions you make? You're saying CBO is going to do this, but shouldn't you folks do analysis of your own to see the effect of the premiums on individuals and families?
We will.
You will. So you're not going to kick it to CBO. You expect to do your own.
Yes.
In the analysis that you've done so far, does it appear that the premiums are going to go up or go down?
It really varies by state and by the individual involved. Because
Well, let's take Virginia, for example.
Well, I don't know the specifics of any particular state. I guess what I was going to say is...
Do you know the particular of any state?
No, I don't know the
Okay,
particulars
okay.
of any state.
Your testimony states that beginning in 2014, the exchanges will provide improved access to insurance coverage choices for an estimated 20 million Americans by 2016. How was this analysis done? Who did it? In-house?
The 20 million comes from the CBO report. In other words, when
So-
CBO estimated both the financial impact and the uptake through the exchanges, that was in their most recent report.
Are these people that already have health insurance, or are these people that don't? It's 20
Well,
million.
it's a combination of people, but it's a number of people that will be eligible for the subsidies that are available for people with incomes below 400%, and then there'll be people that aren't eligible for subsidies but will still access the exchanges.
Would it be fair to say a lot of those people in the 20 million already have health insurance of their own and that your employer provides?
Most of them won't, because again, according to the CBO estimates, you've got a reduction in the number of uninsured in the United States by about 30 million people as a result of the Affordable Care Act. So there are many, many people that don't have access to affordable coverage today that will be able to have that.
All right, I'll just conclude, Mr. Stevens, if you could provide, Mr. Larson, if you could provide this analysis for us, that would be appreciated.
Okay.
All right, with that, the ranking member is recognized.
Thank you very much, Mr. Chairman. Mr. Larson, Senator Johnson seemed to one of his main concerns, and this is a valid concern, I think, is what will happen to employer-based coverage under the Affordable Health Care Act. Because what we tried to do was to build, as you know, we tried to build off of the employer-based system that's already in place while adding some new consumer protections and trying to increase the pool so that that'll decrease actuarial costs. CBO's most recent analysis of the employer-based health insurance coverage under the Affordable Health Care Act, as you know, presented a range of scenarios for potential changes in employer coverage. And Senator Johnson seemed to assume that the vast majority of employers are simply going to drop their employees. But while CBO said it was possible there could be a net reduction, they said roughly maybe 3 to 5 million might lose their employer-based coverage. They also said that, quote, a sharp decline in employment-based health insurance as a result of the ACA is unlikely, end quote. And the CBO maintained its position that the bill will extend health coverage to more than 30 million people. Do you agree with CBO's assessment that the new law is not likely to result in a sharp decline in employer-based coverage?
We don't think it will, and I think if you look at the number of models that other groups have done, whether it's RAND Health or the Urban Institute, or both of those groups have indicated that, in fact, employer-based coverage will increase. And then you're right, CBO estimated a very small reduction in employer-based coverage, but of course that's across a base of about 160 million Americans.
So why would employers choose to keep their people on insurance under the Affordable Care Act? Why would they choose to keep their people on employer-based insurance under the Affordable Care?
There are many reasons. One is that both the employer and the employee get tax advantages from employer-based coverage.
So like if there's a small employer that wants to offer insurance right now, and most employers do, I would think.
That's right.
They would get a tax advantage by offering that they don't have
Correct.
they don't have until this is implemented, right?
Exactly. Yes.
Okay. Now, let's say there are some employees who lose their employer-based insurance. The employer says, I don't want it, you know, they're like the senator, they don't want a federal mandate. So they say, I'm not going to offer the insurance. Those employees could go into the exchanges then, right?
Yes.
Now, what would happen to people like that right now? You know, in the economic downturn, a lot of employers just couldn't offer insurance to their employees. What happened to those employees who lost their employer-based insurance?
Well, they ended up, at least now, without exchanges in the protections in the market, they ended up probably without coverage. It would be difficult to
I mean, they had the option in the individual market right now.
They do.
But that's wildly expensive in most places.
It's expensive, and there's underwriting so that if you have a pre-existing condition in most states, you may not get coverage, or you may have coverage for your pre-existing
So
condition
under the
excluded.
Affordable Care Act, if heaven forbid, an employer drops somebody, they can still
That's
go
right.
through the exchanges.
That's
And
right.
is it anticipated that those exchanges are going to be as costly for those individuals to buy insurance policies as the private market is right now?
Well, the exchanges bring major advantages compared to the individual market today. One is administrative efficiency, and two is a much broader risk pool that's segmented today. And CBO estimated that there were reductions that would occur in premiums as a result of the better risk pool and the administrative efficiency.
Thank you. Now, I want to ask you a couple of questions about the women's health care benefits under the Affordable Care Act. I just want to ask you a basic question. Prior to enactment of the ACA, did all Americans have, and in particular women, have access to basic preventative health services?
No.
Can you give me an example of the types of services that are not currently always covered by health insurance and that will be covered by the Affordable Care?
Well, many of the ones that IOM recommended, including, cancer screening, counseling, domestic violence screening and education, contraception, the recommendations that IOM came up with.
And the IOM did that on a scientific basis, deciding what actually was necessary for women's health care,
That's right.
correct?
That's right.
And HHS implemented the recommendations of the Institute of Medicine?
We did.
Okay. Now, my understanding is that an estimated 20 million women nationwide are already benefiting from these new preventative care requirements. Is that correct?
Well, they're the broader range of preventive services that went into effect already, and of course the specific dialogue about the contraceptive services are on a different schedule.
Okay, but everything except for the contraceptive services,
Yes.
20 million people
Yes,
are already
yes,
benefiting from
that's
that.
right.
One last question. Would you expect that preventative care benefits might result in cost savings, not only for patients but for the healthcare system overall?
Yes.
Thank you.
Gentlelady's time has expired. Dr. Burgess recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Larson, again, thank you for being here. Thank you for the information you've provided our office. In the past law, there was a broad $1 billion implementation fund to administer the implementation of the health care law. Is that correct? Section
that's right.
1005, as I recall. You provided us some documents November 1st that $150 million of this fund had been spent by the center. Is that
150, yes. Sounds a little high to me, but I'd have to go back and look.
well, the October numbers you provided showed $116 million in outlays, so that was about a $35 million increase. But also in October, you provided information that there were $242 million in obligations. Now, the obligation figure wasn't provided for December, but I got to assume that the obligation number had to go up as well as the number for outlays. Is that correct?
I'd have to check because we executed a number of procurement contracts to help with the building of the exchanges, which would be reflected as an obligation, and those were done last year as opposed to the outlays, which
Well,
occur, of course.
here's the question then. Can you tell us today how much money remains unobligated in the implementation fund?
In the entire implementation fund? I can. I mean, as I think you saw in the materials we provided in January, the $1 billion implementation fund is for all agencies at this point. So IRS, Treasury, Department of Labor, HHS.
Sure.
So there are kind of other folks that I would have to consult with to get you that number.
But still, I mean, you know of our office's interest in this, and we're having the hearing, so we need the information.
Okay.
And I referenced this in my opening statement. I mean, the Supreme Court's going to hear this case next week, and whether you think that's a good thing or a bad thing, I mean, it's a fact of life. It's going to happen. They will rule, and they will provide us a ruling presumably before their term ends in June. Now, you may think the likelihood is low that they would agree with Judge Larson in the Federal District Court in Florida that the entire law is unconstitutional, not severable, therefore gone. And you may disagree with that, but there is a possibility that the court will find, in accordance with Judge Vinson's ruling from Florida. Now, I already referenced in my opening statement that you were never authorized in statute, so you don't have to worry. If they void the entire law, you weren't authorized in it anyway, so you'll still be there. But your money won't, will it? If the entire Affordable Care Act were to be struck down, or does your money exist outside the structure of the Affordable Care Act?
Yeah, I hate to say it, I mean, I think that's a legal issue that we'd have to consult with. If the court, consult with our lawyers, if the court were to strike down the law, which we don't believe it will, and that means the entire law as opposed to, certain portions of it. I don't know the exact mechanism that occurs with respect to funding for the law. For example, the $1 billion largely is for the implementation of exchange-related activity.
Just an observation. If I were in your position, I thank God every day that I'm not, but if I had your job and this was out there, I think I would at least have in the back of my mind some contingency plan for what happens next, because you've got all these states that are planning their exchanges. They're all looking to you for guidance. They're waiting on the rules to be finalized. I mean, there's a lot of people whose lives will be turned upside down, and you would be the logical place to minimize that tumultuousness, if that's a word.
Right, but there's a whole range of activities and provisions within the ACA, not just the individual responsibility, guaranteed issue, guaranteed renewability, the market reforms, and of course the exchange provisions, many of which are not, I think, being challenged, although some people would like to see the whole law overturned.
Well, again, Judge Vinson,
many people are focused primarily on the individual responsibility provisions.
Right, but Judge Vinson, in his opinion, said the whole thing went away.
Right.
Donna Edwards, when she was in her testimony, she talked about how women are going to be able to choose any doctor they want without a referral. Section 1311H in the law, and I questioned the Secretary about this, and she seemed absolutely unprepared to answer. Maybe you can help us with that. Under 1311H in the law as written, really you're not going to have the availability of any doctor you want. You're going to have the availability of any doctor that the Secretary says you can have. As I read Section 1311H, the health provider, only if such provider implements such mechanisms to improve health quality as the Secretary may by regulation require. Now, that could be something as board certification, but it could also be quality as determined by will you accept Medicare, Medicaid, as well as patients in the exchange. Have you all looked into how that actual aspect of the law is going to be administered?
Yeah, I'll have to go back and look at that because I have not focused on that particular provision.
It seems like no one is focusing on that within the agency, but it's really going to be quite, again, tumultuous to the provider community out there if their lives are suddenly turned upside down by a ruling by the Secretary of Health and Human Services. So do everyone provide some value in doing that. Thank you, Mr. Chairman. I'll yield back.
Recognized for 5 minutes, the ranking member from California.
Mr. Chairman, the benefits from health reform are already being delivered. Millions of seniors are saving billions of dollars on Medicare prescription drugs. Hundreds of millions of Americans have new insurance protections, and millions of children with pre-existing conditions have access to coverage for the first time, and the law will reduce the deficit by hundreds of billions of dollars. Yesterday, the House Republicans released a new budget plan that turns its back on all this progress. Mr. Larson, what impact would the Ryan budget have on the reforms your office have put into place?
Congressman Waxman, I'll have to defer on that question because I actually haven't had
Well,
time
the Republican budget would repeal the important Affordable Care Act provisions that expand health care coverage.
Mr. Chairman, would yield. Could you submit that for the record?
The Republican budget would repeal the important Affordable Care Act provisions that expand health care coverage and prevent the worst abuses performed by the insurance industry. If the Ryan budget became law, would insurance companies again be able to impose lifetime coverage limits on the 105 million more Americans who now benefit from this protection?
If it were repealed, absolutely.
Okay. If the Ryan budget became law, would the 2.5 million young adults who now have health insurance coverage continue to be covered under their parents' plan?
No.
If the Ryan budget became law, would insurers again be able to deny coverage to the up to 27,000 children in my district and the 17 million nationwide with pre-existing conditions?
Yes.
If the Ryan budget became law, would insurers again be able to spend 30, 40, even 50% of enrollees' premiums on profits and administrative costs?
Yes.
And if the Ryan budget became law, what impact would it have on the number of Americans without insurance coverage?
Well, they'd have the situation that they have today, which is a very challenging, broken market where it's difficult for individuals.
30 million
to access.
Americans would be covered under the Affordable Care Act who are not now covered, and I assume that they will go without coverage if the act is repealed.
As many are today.
There is no Republican alternative to the Affordable Care Act benefits. They offer only repeal, but the Republican budget goes beyond repeal. It decimates all the critical consumer protections in the Affordable Care Act without offering any solutions to the broken insurance market. It puts Americans back at the mercy of the health insurance companies, and it leads to 33 million more uninsured Americans. But that's not all it does. The Ryan budget eliminates Medicare as we know it and destroys the Medicaid safety net, all in the name of tax breaks for millionaires and billionaires. The cuts are staggering and deeply disturbing. The Ryan budget cuts $810 billion from Medicaid by turning it into a block grant, and then another $931 billion from the program by repealing the Affordable Care Act. That's a $1.7 trillion cut over 10 years from the program that protects poor children born with disabilities and pays for the care of our sickest and most vulnerable seniors. The Republican budget could not be more wrong for America. It would roll back the clock on the dramatic benefits we are already seeing from the Affordable Care Act. It would decimate Medicaid, cutting three-quarters of our support for the sickest and most vulnerable people in this nation. It would cut hundreds of billions of dollars from the Medicare program on top of the cuts they all complain about on the other side of the aisle in Medicare expenditures in the Affordable Care Act. They keep that in place. And they would end the program, the Medicare's program, guaranteed benefit for seniors. And Mr. Chairman, this is not the right path for this nation. I yield my
Thank you, gentlemen.
back.
I assume that was a question you had. We recognize on this side, Ms. Blackburn's not here. Mr. Scalise is recognized for 5 minutes.
Thank you, Mr. Chairman. And Mr. Larson, appreciate you coming back to our committee as we approach the 2-year anniversary. I know a lot of the questions that many of us have deal with the effects that we're already hearing from our constituents about. And, you know, unfortunately, the constituents that I talk to, and especially our small business owners who I constantly meet with back home, the biggest complaint that they have is that under the rules they've already seen, let alone the rules that haven't been written, they don't see how they're going to be able to comply with the law. And in fact, many of them are facing the not desirable option, but the almost necessity that they will no longer be able to provide health care for their employees. We've seen reports that millions of Americans will lose the health care that they have today that they like. You know, with that, one of the big promises that President Obama made was, if you like what you have, you can keep it. Do you feel, you know, you're under oath, do you feel that that promise has been kept?
Yes, I do, absolutely. And I think that...
Well, are you denying then that there are already, you know, millions of people that are facing losing their health care because of this law that they like?
Well, it's not because of this law, and I think if you look back...
That might be your opinion. I don't know if
the last 10 or 20 years, and I've been doing this for a long time, starting with when I was insurance commissioner, even back in the 90s, the rising insurance rates for small businesses was a huge issue, and that continues today, and it really illustrates why we need the Affordable Care Act.
Well, but if you go back to the beginning of the debate on the health care law, you know, three or so years ago, The biggest problems back then were cost and other problems like discrimination against people based on pre-existing condition. Now, we put forth legislation that would have actually scored to lower the cost of health care. That was rejected by the president. We put forth legislation that would prevent discrimination based on pre-existing conditions. The president's health care law has actually been scored to have increased the cost of health care. It actually made it worse. The cost is worse now. In our small businesses, and maybe you talk to different people than I do, and I guess that gets to this question of the waivers. So many small businesses I talk to would love to have a waiver from the law and even components of the law, and I know, we've talked about this waiver issue before, but seems like there was a lot of crony capitalism that was played in issuing of waivers to people that, in many cases, helped support the law, came to Washington and said, pass this law, it's important to pass, and then they went to the White House and got a special waiver from the law. How many waivers have been given, from...
Well, first I do have to say that's not how the process worked. We ran a very open, transparent, fair process that didn't favor anybody based on what their
why is it
political
that
background.
Small businesses I talk to, not one of them heard about the waiver program. Not one of them. And I tell them about it. They say, hey, I'd love to get it. I mean, we got a list here. What's the current? No, I've got over 1,400 companies that got a waiver from Obamacare.
Well, the waiver
and yet
was,
small businesses I talk to never even heard about it. And once they heard about it, y'all ended the program.
Well,
but
the
you
waiver was
in all
for
the
a
friends.
very targeted group of employers that offered these mini-med policies that many people don't like. They don't provide great coverage. Employees that are
According
in
to
these
you,
mini-med policies.
if somebody has no coverage versus that coverage, then and they like that coverage, you're going to sit here and testify
Well, that's exactly
under oath
why
that
we
that's
had a
not
waiver
bad,
program.
that's not good coverage. What if they think it is good coverage?
We came
Shouldn't
to the
that
same
be their
conclusion.
choice?
We came to the same conclusion, which was in the law, the ACA specifically permitted and authorized and contemplated this, where you would have these groups of policies. They're a small percentage, but nonetheless they are something for people that have them. So the law permitted the secretary to set up a waiver program. We did that for exactly the reason that you suggest, so that people that have that coverage, even though it isn't great coverage, it is something,
right,
and they can continue.
But
that
did you
for
end the
24
program? I mean, this waiver program, a new company that now knows about it, because a lot of companies have heard about it because we've been telling them, you go look, a lot of these labor unions that came here and said, pass this law, we need this law, they went to the White House and got a waiver.
Well, they did.
We got the list. They're here on the list.
The White House didn't make the waiver decisions, and only 2%.
You did.
Only
they
2%.
found out about it again. It was, I call it crony capitalism because it was a lot of the people who supported the law found out about it. Now, you say it was advertised.
No, it was.
Most small businesses never heard about it. So you didn't do a good enough job of advertising, or maybe you only advertised to people who supported the law. But it's curious that most people that I talk to that don't like this law, that are trying to figure out how to comply with it but can't, they didn't even know about this waiver program that you say was so well advertised, yet so many of the groups that came here and said pass the law conveniently found out about the waiver program and got it. They got a waiver from a program that they said we needed. They got the waiver. And the companies who didn't want it can't get the waiver. And now you've ended the waiver program? And can a company that didn't know about the waiver program that now knows about it, can they apply for a waiver today?
No, but I can say that small businesses were a very large percentage of the people that
so
came in to get the
So the
waiver
companies, and I've seen a long list of Fortune 500 companies that got the waivers too, but a lot of, AARP, groups that supported this law, got the waiver. But these small businesses I talked to, they never even knew it existed. They'd love to get the waiver now, and you're telling me under oath that they can't get it today.
That's right.
So the other companies that got the waiver, are you going to take the waiver away from them, or are you going to let them keep it?
No, they got notice, they applied, they met
So
the
they
criteria.
get to keep it. The guys that knew about it, the friends that helped pass the law get to keep the waiver from it. They don't have to comply with it. And the folks that didn't want the law in the first place,
the
now
GAO looked
can't
at the
go
way
get
we
it.
ran the process and found that
That's
we
crony
ran
capitalism. I
according
yield
to
back the balance of my
Yield
time.
back the balance of
I
time.
would just make an observation, which is if members would actually like the witness to answer questions, I would suggest they would stop badgering.
Well,
and in
it's not
addition, I
badgering.
would
He answered a
suggest
lot
that
of
you would
questions.
give them
With
the
the gentlelady,
time to answer the question.
That's not badgering to ask questions. I mean, they might be tough questions, but that's why we're here, is to ask the tough
We
questions.
recognize the gentleman from
He's
Michigan.
capable. Mr. Larson's capable of
Mr.
doing
Dingle,
his
you're
job. He's done a
recognized
good
for 5
job.
minutes.
Would you like an
Take the
answer
floor.
to that?
You're on.
Thank
We got
you.
answers.
Coming to the waiver question, I'd like a yes or no. At the time of this hearing, waivers have been granted over 90% of the applicants. The average wait time for decision is 13 days, and union health plans are less likely to receive waiver than non-union plans were. Isn't that true?
That's true.
Now, some other yes or no questions. As you know, the Affordable Care Act provides $40 billion in tax credit for small businesses so that they may offer health insurance to their workers. I believe it is true that in 2011, 360,000 small employers took advantage of the small business tax credit, providing insurance for better than 2 million employees. Yes or no?
I think that's right, yes.
Is it true that since the implementation of the Affordable Care Act, that Medicare Part B deductible has gone down for the first time in Medicare history? Yes or no? Is it true that over 2 million additional young adults are now insured because ACA allows them to stay on their parents' plans until they're 26? Yes or no?
Yes.
Prior to ACA, many people faced lifetime limits on health insurance. These limits had potential to financially crash them if they faced a chronic disease or severe illnesses such as cancer. These limits would also force them to make decisions to compromise the quality of health care. Isn't it true that since the implementation of ACA in 2010, 105 million Americans no longer face lifetime limits on their insurance?
Yes.
Is it true that once the Affordable Care Act is fully implemented in 2014, 20 million more Americans who still lack coverage will become insured? Yes or no?
Yes.
Is it true that CCIO's implementation of the Transitional Pre-Existing Condition Insurance Plan led to health coverage for tens of thousands of previously uninsured Americans?
Yes.
Is it true that CCIO is moving now towards full implementation of the Affordable Care Act in 2014 by working with states to make sure that the health insurance exchanges required by ACA are designed properly and meet the needs of each of the individual states?
Yes, sir.
Finally, as we move towards the future, I am very much concerned about the Americans who will lose coverage if my colleagues on the other sides are successful in repealing this bill. Am I correct in saying that 33 million Americans will lose insurance if my colleagues on the other side of the aisle repeal ACA?
Yes.
Now, wouldn't such an increase in the number of our insured in this country increase costs to the health care system?
Yes.
Now, isn't it a fact that that ACA has in fact reduced the deficit?
It is projected to reduce the deficit.
All right. Now, isn't it a fact that in 2008, people without insurance did not pay for 63% of their health care costs?
I think that's right.
All right. Now, when President Obama was elected, he quickly recognized the inescapable truth. An individual mandate was essential to make the plan work. Without that, the larger pool of premium payers, there is no feasible way to require insurance companies to cover all applicants and charge the same amount regardless of the health status of the beneficiaries.
Individual responsibility is an important part of the
now,
matrix.
I believe this is an overwhelming truth. Those with insurance now are supporting those who do not have insurance, and they're winding up paying much of the bill for those who do not have insurance, and that those people are running up health costs of about $116 billion.
That's right.
And so this means that the families and persons with insurance are now paying more than $1,000 a year for those who do not have health care.
That's right.
Now, the function of insurance is to spread the risk. Previous to the time ACA was passed, we find the insurance companies had to avoid the risk. And so now we have a broad pool which covers everybody. Isn't that right?
That's right.
And that makes it possible for insurance companies to do the things that are mandated in the ACA. Isn't that right?
Right.
And without that, we're going to go back to the dismal days when we were not able to take care of our people, see to it that young people stayed on their parents' policies, and we won't be able to see to it that pre-existing conditions are dealt with without cost and charge to people.
That's right.
Thank you, Mr. Chairman.
Thank you, gentlemen. Mr. Griffin is recognized for 5 minutes.
Thank you, Mr. Chairman. Our staff is going to hand you some excerpts from the February 17th, 2012 Early Retirement Reinsurance Program update. This is a list of those who received money from the program. Now, before I'll give you a second to take a look at that as well. But before I get to that, as I understand your testimony, the Early Retiree Reinsurance Program has spent $4.73 billion of the $5 billion allocated. Is that correct?
That's correct.
Now, that number appeared in that February 17th report and in your testimony today, but surely there has been some of the small amount left spent in that last month. Is that not true?
Well, there will be, because as we go through and make sure that all the claims have been submitted appropriately,
okay.
it may turn out that we
But at this point, it's certain that
$4.73
$4.73 billion of the $5 billion has already been spent.
We're effectively at the end of the program. There will be some continued review
all right.
of claims.
But wasn't the program supposed to go through 2014?
I think it was originally intended to go through 2014, but many sponsors took advantage of the program, which I think
okay.
reflects the outstanding need for the program.
If you take a quick look at that material that was handed to you, because give you a second to absorb what it is.
Is there anything in particular you want me to highlight in ones?
Well, I'm getting ready to ask you about all
okay.
those companies that are highlighted.
Okay.
All right. Could you provide me a yes or no answer to the following? And I'm going to ask you which of the companies I'm going to name off if they received money from the Early Retiree Reinsurance Program. And I think the ones that you've got that I'm going to ask you about are highlighted so you can see them easily. ConocoPhillips?
Looks like they did, yes.
General Electric?
They're listed here as well.
General Motors?
They are listed on the sheet that you've given me.
Bank of America?
They are here.
Ford Motor Company?
I see Ford Motor Company.
Hewlett-Packard Company?
That is here.
AT&T?
Yes.
J.P. Morgan?
Yes.
Citigroup?
Yes.
Verizon?
Yes.
AIG?
Yes.
IBM?
Yes.
And what we just went over is a list of companies that are not just in the Fortune 500, but that receive this taxpayer money, but are companies that are in the top 20. 12 of the top 20 of the Fortune 500 received money from this program. And I think you told us in a previous hearing that that's because the underlying law didn't make a distinction for those that needed the money. It was just out there if you met the criteria.
The law was based on the fact that historically the number of companies that are able to provide retiree coverage has dropped off, I think, by half in the last 10 years. So it was not needs-based. And I think, as you probably saw, many of the biggest recipients of the funds were, in fact, state retiree programs, state teachers, state employees.
One of my concerns, though, is that if the intent of the bill was to give this early retirement assistance to companies so that they could fund their programs,
Mm-hmm.
I think we have the same problem Mr. Scalise pointed out. A lot of the big companies got in. The rich folks got it because they had people to monitor all this stuff and keep track of it. I'm not sure that the small companies that probably needed the assistance got it. Wouldn't you say that's a fair assessment?
I don't think so. We've had, I think, over 2,800 sponsors of a wide range of size and background come to get money from this program. Remember, it's got to be companies that are already providing benefits to their retirees, so that's typically going to be some larger companies, although, as I said, it's frequently states and their state employee retirement systems that got the money, as well as some of the companies you mentioned here.
Now, you said in testimony, and I'm switching gears on you, you said in testimony earlier that this would not necessarily be enforced, that the act would not be enforced by your agency but by the IRS because it was part of the tax.
You mean back to the individual responsibility
yes.
provision?
And that would be enforced by the IRS. Is that the 16,000 new IRS agents we've heard so much about?
I don't believe so. I don't think that's how it's enforced. It will be enforced electronically through the filing and through the verification of whether someone has purchased insurance. Remember that, and that doesn't occur until 2015 because that's when the responsibility provisions actually kick in to confirm that someone had coverage in 2014.
All right, my time is just about up, but I want to ask you about CBO. Said it's going to cost more than the $1 trillion that we were originally told it was going to cost when this passed before I got here. And it looks like, is it fair to say that based on that information over the 10 years that this may actually cost $2 trillion or more dollars, this program?
Actually, the CBO report found that there would be about 50 billion fewer costs associated with implementing this because of the number of changes that they highlighted. So the numbers in the CBO report that just came out said that over the 10-year period from 2012 to 2021 would be 49 or 50 billion dollars less than what they had projected a year ago in March of 2011.
But it's going to be more for the first 10 years, isn't that correct? Isn't that what the CBO said?
No.
All right, I yield back, Mr. Chairman.
The gentlelady, Ms. Christensen, is recognized for 5 minutes.
Thank you, Mr. Chairman. And Mr. Chairman, before I ask my question, I just wanted to make some comments about the early retiree reinsurance program because the attacks on it are really unfair and unjustified. Prior to the passage of the Affordable Care Act, employers were dropping coverage for their retirees at an alarming rate or finding themselves saddled with huge and rapidly increasing health care costs. The program was an effort to help employers bridge the transition to 2014 when more affordable coverage options will be available. And in the face of overwhelming need, the ERRP program had great results. The program has helped more than 2,800 employee health plan sponsors across the country cover the cost of medical care for early retirees. These plans cover more than 19 million beneficiaries. ERP funds support employers that continue to provide private health coverage and help early retirees keep the private coverage they already have. This important transitional program worked to support employers making the right choice for their retirees, and I think it's an important way to support that choice. But Mr. Larson, let me ask you some questions about the pre-existing condition insurance plans. You testified before the subcommittee on April 1st to discuss the pre-existing condition insurance plans, the PCIP, or high-risk pools established under the Affordable Care Act. In that hearing, we heard about thousands of Americans with pre-existing conditions who finally had access to coverage. And we've established that maybe somewhere around 50,000 Americans have enrolled in the PCIP. And I understand that many of these individuals have serious health conditions, including 1,900 individuals with cancer and nearly 4,700 with heart disease. What type of coverage options did these individuals with pre-existing coverage have before we passed the Affordable Care Act?
The fact is that they really wouldn't have any other coverage options. I think many of these people would be diagnosed with cancer and end up in the emergency room or not get care at all for their condition.
And how will those options improve in 2014?
Well, when the insurance reforms kick in, at that point we'll have guaranteed issue, guaranteed renewability, and so we'll have a much larger insurance pool, and people that would get locked out of the system today by the insurance companies won't be locked out in the future, but we'll also have many, many more people in the insurance pool to offset those costs.
Thank you. The only complaint I have about that program is that it didn't extend to the territories, Mr. Larson. Still working on that. But, you know, Republicans should love the PCIP program. It's been the centerpiece of their past reform proposals, but instead they attack it because they say it's not popular enough, unless, of course, they're attacking it for the opposite reason, that it's too popular and may spend too much money. So, Mr. Larson, what happens if the program becomes so popular that the expenditures might exceed $5 billion?
Well, we have to manage within the amount that Congress has appropriated for this. So we continue to monitor the progress that states are making in their enrollment and their costs, and if we have to make adjustments in the future, we'll do so.
Are the procedures in place to make sure that they don't exceed the program costs?
Yes, we have to make sure that we don't exceed program costs.
And what happens if you do not spend the entire $5 billion?
That's a good. I don't know the exact answer to that, but I will say that if we exceed our costs at some point, then there are a number of different options that we can pursue to make sure that we stay within the $5 billion.
Okay, so we have a win-win scenario here. In one case, the program becomes extremely popular. Many people receive coverage, and you still have processes in place to protect taxpayers and to make sure expenditures do not exceed authorized amounts. The other scenario involves low enrollment. In that case, I think what happens is you'll return the extra money to the Treasury, which would help reduce the national debt. So I appreciate you walking us through the money, how the money is being spent. I know that there are many unfair attacks against the health reform law, the Patient Protection and Affordable Care Act, But I think the record is clear that you are administering the PCIP program and the law as a whole in a very effective and efficient fashion, and it's a humongous task. So we really commend CIO and the entire department for the way that you're doing it. And I do have some specific territory-related questions that I'll submit for the record.
Okay.
Thank you, Mr.
We'll
Chairman.
look forward to answering those.
Thank you. Now, Chair recognizes gentlelady from Tennessee for her 5 minutes.
Thank you, Mr. Chairman and Mr. Larson. We are pleased that you're back with us today. I want to talk about the nonprofits. You said that you had awarded more than $638 million in loans already from the Consumer Operated and Oriented Plan, but OMB has estimated that under the co-op program that taxpayers could lose $370 million from unpaid loans to the nonprofit insurers. And do you think that's accurate? Are we missing something here? Are they missing something?
Well, I guess for purposes of the loan program, OMB has to make some type of projection, as they would for any loan program, about the rate at which recipients would not repay their loans. I can tell you that in our review process for the applicants that we got, we hired an outside consultant with extensive financial expertise to look at the applications that we got. So OMB has to make some assumptions, I guess, for purposes of releasing the money, but we are running a very vigorous process, and we think that the
basically you're saying this is a bad investment for the taxpayer.
Not at all. No.
You're not saying that.
I'm
You're
not
saying the
saying that.
taxpayer should expect to lose money because
No,
$370
I'm not.
million
I'm saying the
would be
opposite.
nearly a health care Solyndra. Well, you just told me that you thought OMB has to expect a certain amount of this, and you know, if they're saying as much as 50% of the loans issued under the program may not be repaid, I mean, do you think that's accurate?
We don't think there's going to be a default rate on these loans. I think they have to make projections for certain purposes. But again, I can tell you from our perspective, we're doing everything we can to make sure that we only provide the loans to
then
financially.
let me approach it this way with you, because reading this is of concern to me. And after what this committee has been through, looking at the DOE loan program and the bankruptcies that are there, let's kind of agree to get out ahead of this. And what I would love for you to do is to submit the analysis and the documents related to the program, and then your approval of or rejection of the loans. I think as we oversee this, that would be very helpful to do that. Would you submit that to us?
Yeah, assuming that we can provide that application material, but I'd be happy to kind of explain for you exactly what process we ran to make sure that we got the best applicants possible.
I've got just a little bit left, and I do have another question for you. Last time you were with us and we discussed the waivers, I asked if you had a plan B for when the waivers ran out, and you did not have a plan B. And now we're looking at, 1,800 waivers that have been given. As you look at your cost in the coming years, and you look at 2014 when these waivers run out, have you come up with a plan B for how you're going to integrate these programs and what the expectations are going to be for the impact on the system?
Well, essentially the plan B or the transition is that in 2014, when the requirements of the annual limits provisions would apply, these mini-med policies would no longer be offered, because employees would have access to full comprehensive coverage. Many of them would be available, would be able to access the tax credits that are available, because it's often lower income workers that are in these mini-med plans, and those are exactly the kind of people that would have access to the tax credit in 2014.
Okay, all righty. As you've gone through the waiver program, how many people were denied waivers? How many companies were denied waivers?
It was we approved over 90%. I think it was only, 90 or 100 that were denied.
Okay, and the waiver program is closed. You can no longer get a waiver? Okay, all righty. The ones that were denied, what was the reason for the denial to them?
Well, to be approved for the waiver program, you had to show that applying the high annual limits, at the time $750,000 annual limits, to your policy would result in a substantial increase in premiums or a decrease in access to coverage. So for policies that say had coverage of $25,000 or $5,000, which are these mini-med policies, typically applying that standard to them, it would raise premiums. Some people might not be able to afford them. So that's how you were approved for a waiver. If you weren't approved for a waiver, it meant that you didn't meet the regulatory criteria. In other words, it wasn't going to cause a large increase in premiums to comply with the annual limits provisions that were in place at the time.
All right. Yield back.
Thank the gentlelady from Tennessee. Now we recognize the gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, and again, welcome, Mr. Larson. I know there's some concerns, and our committee actually spent a lot of time on the Affordable Care Act, and we were marking it up both in our subcommittee and the full committee 2 years ago. And I have a district that's has such a huge impact the Affordable Care Act will do. Before the passage, the 29th district that I represent had the largest percentage of uninsured in any district in our country. Very urban area in Houston, again, not a wealthy area. We still have a lot of work to do, but things are getting better. As many as 53,000 children in our district can't lose the security offered by health insurance due to pre-existing conditions. 3,400 seniors have saved an average of $540 on prescription drugs, and 9,000 young adults have health insurance they couldn't have before the Affordable Care Act. Additionally, about 60,000 of my constituents, most of them in minority and historically underserved communities, are receiving an array of preventive health services without copays, coinsurance, or premiums. And this is a result of the Affordable Care Act and its tremendous help toward reducing health care disparities in our district particularly, but in our country. I'm proud to represent part of Houston. We have a great Texas Medical Center there, I think one of the largest in the country. It's just hard for my folks to get there except through our public hospital system. Individuals in underserved communities, minorities, rural areas, and communities with high poverty rates need the Affordable Care Act. And I'd like to ask you some questions about how this act is serving the underserved area. First, what are some of the biggest barriers to access to care for these underserved communities? Again, very urban like mine, or even rural areas.
Sure. One of the main ones is cost for lower income individuals, the cost of coverage and accessing coverage. And the Affordable Care Act, of course, addresses that through the tax subsidies that are available for people.
The health care law provides billions of dollars in public health grants for community health centers expansion. I know we have received some of those grants in our district, and we need more because Houston and Harris County is the fourth largest city in the country, and yet we're behind the curve on community-based health centers. And I know a few years ago when we authorized it, we had a provision in there that if you're a very urban area, and all being equal, if you had a huge underserved population, that your grant application was given a higher priority. I know that is helpful, but in the Affordable Care Act, will some of these barriers will help address some of those barriers, expanding of health care providers and community health centers?
They will, and there are provisions in the exchange rule that requires network adequacy to make sure that health plans have a full network of providers, and including essential community providers, which are an important part of the support for the individuals you're referring to.
Can you just verbalize some of the preventative health care benefits that we're seeing now on the second year anniversary?
Well, there's a whole range, particularly for wellness visits for both women, for children, cancer screenings, colonoscopy screenings. Almost, the things that have been approved by IOM that have shown to be effective in terms of prevention.
Okay. I realize this is not your area, but the health care reform law also contained funding and new programs to help expand the health care workforce, especially primary care workforce. Can you give us an update on how that will help not only minorities and underserved, but individuals in those underserved areas?
I know that there's substantial funding available in HHS for a number of workforce initiatives, which is extremely important, and it's significant, the details of which I don't have in front of me, but I know that it's a key part of this law.
Finally, the Affordable Care Act coverage provisions, the expansion of Medicaid, new health care credits for small businesses and the state insurance exchanges that will make health insurance less expensive and easier to obtain for individuals. I know, for example, in Texas and a lot of states, I think 26 states are waiting until the Supreme Court decides whether they're going to participate. Even though my home state received planning money for it, they've decided to wait. But even if they're waiting, HHS will provide an exchange system for those states that do not participate. Make that decision.
We will, one way or another. There will be an exchange for the healthcare consumers in each state, including Texas. Although many states, even states that are challenging the law, actually have applied for and received extensive grants and are moving forward to be ready in 2014.
Well, and I know in Texas, but again, a political decision's been made. But
right.
Hopefully, the Supreme Court will come back with the argument and realize that health care is just like Social Security, like a lot of other things, Farm Bill, things like that. That Congress has the right to make that a mandatory. So, Mr. Chairman, thank you for your time.
Thank you, Mr. Green. Chair recognizes the gentleman from Pennsylvania, Mr. Murphy, for 5 minutes.
Thank you, Mr. Chairman. Mr. Alderson, do we have any numbers yet of what we estimate an individual pay for their premium and copay under new insurance plans with the Affordable Care Act?
I don't have an estimate, and the estimate really varies depending on the state and how old they are and whether they're buying in the individual and small group
Will
market.
it be $1,000 a year, do you think?
I don't know.
Well, current policies now average what nationwide that individuals pay?
I think the typical estimate is for $12,000 for
Okay.
individual. I think that's in the individual market, though.
Okay,
Right.
I understand. So now, with regard to this plan, is open enrollment year-round? A person can sign up for an insurance plan?
No, there'll be open enrollment periods. In the reg that we put out, there are open enrollment. There's an initial open enrollment period that's a little longer, and then each year there'll be open enrollment windows.
Okay. And do we have estimates of how much we think that coverage under the Affordable Care Act will increase or decrease? I know part is the mandate everybody's supposed to get a policy. There's some beliefs that will somehow have an impact, but do we know exactly how much it may reduce individual costs, keep it the same, increase, slow growth?
There are a number of different estimates. I know CBO did one that said for the small group market it could be flat to advantageous because of the economies of scale you get coming in. It somewhat depends on, in a particular state, whether they have a full range of benefits today or a modest range, and then you get, of course, the efficiencies in the individual market of having everyone in one single insurance pool in a state.
But as far as the states go, there still is a required amount of coverage that each plan has to have. That some states.
That's the essential health benefits.
So some states have very few mandates, some states have a lot. But this will have a set amount that every plan has to have, so people can compare.
One of the things we just did in the bulletin that we issued was to allow states to select their own benchmark plan for essential health benefits. So you're exactly right. In some states, they have more mandates than other states, and that state could select that as their benchmark. And the state that has a a thinner mandated benefit package, assuming that it kind of met the basic criteria, could choose that as their benchmark.
So we're still not clear on this, but now we do know that if an employer drops coverage, they would pay a $2,000 fine.
There's a penalty, yes, for not offering coverage. If you're,
and I've seen estimates all over the place. As have you. I've seen some as high as they think 85 million people may not be covered. Some say maybe 10 million. It's all over the board. Some say 20 million. Number of people won't be covered by employers. Does that sound right? We're seeing estimates all over the place.
I'd say this: there are many different estimates, but I think most of the estimates suggest that there, like CBO, there could be a small number of people that have it today that might not have it then, but then there are many other people that don't get it offered today that will have it offered in the future. So when you net those things out.
Big question mark there still. I know that it's estimated about $40 billion a year is lost from people for uncompensated care that hospitals say they need that money, or is it more than that? Do you know?
Right. That was one of the premises of the act, is that we all pay for that uncompensated.
And what they're looking at, so an employer may drop coverage and pay a $2,000 fine. As I understand it, an individual, if they choose not to have coverage, they'll pay, I think, a fine of $695 or 2.5% of their income, whatever is higher. Am I correct?
Right.
Now, given that what people are facing here now, there's multiple open enrollment periods during the year. You have people who are also facing increased energy costs with the the policies where many coal-fired power plants are going to drop. We're going to lose about 20% of our power generation, so people's electric bills are estimated to go up 30 to 40%. With gasoline costs going up now, where an individual this year is paying about $2,500 or $5,000 more a year, families are going to continue to make individual choices. So although there's a mandate to require people to purchase health care, you still can't make them purchase health care. If they decide to not purchase it, they can still hold off and not purchase it.
Well, they pay the financial penalty.
Pay the financial penalty. But if they say, look, I'll pay $695 versus several $1,000s, they may make that decision.
Some could, although for many lower-income individuals up to 400% of poverty, there are the tax credits available that significantly offset the cost of
a tax credit for someone who's on poverty and doesn't pay taxes?
Well, many of them do. I mean, obviously people that are on Medicaid may not, but the credits are available for people up to 400% of poverty, which
just
actually
in my remaining time, the issue that still baffles me is the preventative care issues. I mean, we know that there's decreased costs for people who don't see a doctor, who eat. There's decreased costs for people who eat healthy foods, decreased costs for people who have optimal weight. I think obesity costs our healthcare system $147 billion a year. Decreased costs for people who exercise regularly, follow their prescriptions carefully. I think misusing prescriptions is a $250 billion drain a year. People who are chronically ill, if you monitor them, work with them on health, they can be a 40% cost savings. If this is where all the costs are, will we be mandating those things in order to really save? Because those things add up to be several $100 billion a year. Will we be mandating these behavior changes too?
Well, not behavior changes, certainly, but there are a lot of incentives in the Affordable Care Act for health and wellness programs for insurance companies who will get credit on their medical loss ratio calculation if they provide health and wellness programs.
So you're believing that the financial incentives can help people drive to behavior changes on this versus mandating them?
I think in this case, yes, for the health and wellness.
Thank you.
Gentlemen's time has expired. I think we are ready. We could go, I tell you, to my ranking member, we'll go a second round, Mr. Larson, and I'll start with this, and I tell members who would like to take a second round, stick around. Let me just start by sort of asking you, Mr. Larson, a sort of general question. We've heard from Mr. Waxman and others how the cost of health care is going to come down. Do you actually believe that the health care in America will come down? Is that what you're saying us today, that the Obamacare will cause health care to come down?
Well, many aspects of the ACA will lower health care costs. First, by getting more people covered.
I understand.
Right.
But has it lowered premiums so far? I mean, this bill's been enacted 2 years. Have you seen the premiums come down, in your opinion?
The provisions that help address the
yes or no?
insurance premiums
Yes or
don't
no?
take effect until 2014.
So you say it's too early to see the impact of Obamacare?
Well, with respect to premiums, I mean, we've expanded coverage. We've provided people with better coverage. The provisions that help address some of the cost efficiencies with the exchanges,
But the fact
of course,
is
don't take
that
effect until
health
2014.
insurance premiums have shot up 9%, 3 times the rate of inflation. This is according to the Kaiser Family Foundation. And I think you would agree that the Kaiser Family Foundation said the costs have gone up 9%, 3% above inflation. Wouldn't that indicate that a lot of the things that you've talked about that have been implemented have really not brought costs down?
Well, first of all, that rate of increase has been consistent over the last 10 years, which is why we need to make changes to the system.
It's not changed with Obamacare.
Well, in fact, I think the CBO in their recent report found that the rate of healthcare spending and premiums had actually moderated in the last year when they looked at the estimates for the cost of the ACA.
Don't you think that's probably the economy more than anything that
Well, it could be a number of factors. I guess what I'm saying is that we don't think the provisions of the ACA are what's at work when you look at the historical rate of increase of premiums year over year. The ACA will help fix those provisions.
Okay. So, Mr. Larson, you're saying today we can expect health care costs for families to go down?
We hope that and expect that costs will moderate with the provisions of the ACA.
Now, the President indicated he promised lower premiums by an average of $2,500 per family. Do you think this is going to happen?
I think costs will be much lower compared to what they would have been if the ACA hadn't been enacted.
Your testimony talked about the rate review of insurance increases in New Mexico, Connecticut, Oregon, New York, and Rhode Island, correct?
That's right.
In any of these situations, did the premiums go down?
I think in the
Yes or
examples
no?
we cited that the insurance commissioner in that state worked to lower the initial rate filings that came in.
Well, I think your testimony indicated that the rate review situation resulted in premiums going up. The government really said they couldn't go up so much, but I think that's true.
Oh, I see. You mean the increases were approved, but they were lower than what originally was filed by the insurance company.
Yeah.
Right, right.
Where
That's
in your
right.
testimony today did you discuss lowering premiums?
Well, lowering, it's all relative, right? I mean, lowering premiums means lower than what they would have been if we hadn't had these types of provisions.
That's like we do in Congress. We say we reduce spending by lowering the spending more than we projected. So your testimony, the example you cite, you say the quote, the Government Accountability Office found that in a survey of 7 insurers, most of the insurers were adjusting premiums, end quote. Is that it?
Well, that was a result of the medical loss ratio provisions. I think GAO did a very limited survey of a number of companies to see whether they were taking action to comply with the MLR and what it was. And in some cases, companies were moderating their premium increases. We did have an example, and there may be others, of a company that did actually lower premiums. There was a case.
Can you give me a specific example?
Aetna Insurance Company in Connecticut actually lowered premiums.
Okay. So is that the only one, Aetna of Connecticut?
Well, that's the one that I'm aware of.
Can you name anyone else that has lowered premiums specifically because of Obamacare?
Well, when you say lowered, you mean moderated the premium increases that would occur?
To use your term.
I can find that and get to you in writing, because yes, many companies have been on the record, both with us and in Wall Street, indicating that they were moderating their rate increases based on the MLR provisions in the Affordable Care Act.
Do you provide waivers if companies find out that their premiums are going up significantly? Is that one of the factors which you provide a waiver for?
Well, in the waiver program that we don't operate anymore, but at the time, that was one of the criteria. Yeah. That's right, yeah.
Mr. Scalise talked about, I don't know, 1,200, 1,400. I think there's 1,700 entities that got waivers. Isn't that true?
Overall, though, that included about 400 or 500 of companies that offered HRAs or health reimbursement accounts that we really concluded didn't need a waiver under the law. So
yeah. All right.
The number's actually less.
My time has expired. Mr. Dingell is recognized for 5 minutes.
Thank you, Mr. Chairman. You had, first of all, Mr. Larson, given us a very good statement today. And Mr. Chairman, I think that the information we've gotten in this hearing has been most helpful in understanding how we're doing and moving forward, and also in having some significant appreciation of the chores which yet remain. I think if we all are willing to work together, we're going to see this program be a good one of which we will all be proud. Mr. Larson, you made some points here. States are already using, in your statement you said, states are already using this authority to save money for families and small businesses. Start out in New Mexico. The State Insurance Division denied a request from Presbyterian Healthcare for a 9% rate hike, lowering it to 4.7%. In Canada, the state stopped Anthem Blue Cross Shield, the state's largest insurer, from hiking rates by a proposed 12.9% instead of limiting it to a 3.9% increase. In Oregon, the state denied a proposed 22% rate hike by Resurgence, or rather by Regency, limiting it to 12.8%. New York, the state denied increases for Emblem, Oxford, and Aetna that averaged 12.7%, holding them instead to an 8.2% increase. In Rhode Island, the state denied rate hikes to United Healthcare of New England ranging from 18 to 21%, instead seeing them cut to 9.6 to 10.6%. I know what you're telling us, that these provisions are working in terms of assuring the protection of consumers.
That's right.
Is that a fair statement?
Yes, sir.
Now, we've talked a little about the health insurance exchanges. you will note that as you've indicated, CSIO is charged with helping states set up these exchanges. Isn't that right?
Yes.
How will these exchanges change consumers' experience in purchasing health insurance on the individual market?
Well, individuals will now have access to a competitive market, an affordable market.
So he'll know what he's getting?
They'll know what they're getting, and they'll get comprehensive coverage, and they'll have the ability to get tax credits if they're
And it
they
will
meet
be
the
written
criteria.
in a simple, understandable way,
Yes.
so that the purchaser of the insurance policy will be able to understand what he's buying and what the advantages of the different plans might happen to be. Is that right?
That's right. Exactly.
And you're going to need to be a Philadelphia lawyer to understand this. Is that right?
That's right.
So, so in addition to improving the market for individual coverage, then we must assume that the exchanges will also provide for small businesses to have, for the first time ever, the ability to pool their risk and buying power together to drive down costs. Is that right?
That's right.
Now, there seems to be some misunderstanding here. Insurance companies over the years have been forced to go to the idea that they will avoid the risk because they didn't have a decent insurance pool. So what they did is they curtailed the size of the pool by getting rid of the most risky people, and that's why they used pre-existing conditions and other things to prevent people from certain classes of people from buying insurance. Is that right?
That's right.
So now the insurance companies are going to be able to engage in the practice that is so important in terms of having real insurance. They'll cover everybody.
That's correct.
And this is going to enable insurance companies to then practice insurance in the classical sense by making it available to all persons, and then we will all share the risk that flows from the possibility of sickness or illness or debilitation. Is that right?
That's correct.
All right. And this is one of the main ways in which we're going to see significant savings of monies to the federal government, to the employers, and to, of course, the purchasers of the insurance. Is that right?
That's right.
Okay. Mr. Chairman, I'm going to surprise you. It's 38 seconds. I yield back.
All right. Thank you, Mr. Dingell. Dr. Burgess, recognized for 5 minutes in our second round.
Thank you, Mr. Chairman. You know, I'm tempted to actually go to the left of John Dingell, but I'm going to resist the temptation. Let me, but he was talking about, and we do this all the time, the ERISA market is not the same as the small group market and the individual market. Mr. Dingell's questions really were about the small group market and the individual market, not the employer-sponsored insurance market, because pre-existing conditions are covered then in the open enrollment period, are they not?
You mean for the self-insured market? Yeah.
No, I'm talking about for someone who works for, say, a big telecom company that's known only by its initials.
That's one of the big advantages of working for a large company.
Right,
They're not
but
subject to the...
those individuals in the large group market were not subject to the same constraints that Mr. Dingell was just discussing. Is that correct?
Typically, that's right, yes.
And it really seems like had we wanted to reform the system, we would have tried to help the individual market and the small group market behave more like the large group market. And I think we could have gotten a lot more bang for the buck. But that's another story. We didn't get to do it. Am I going to be able to keep my HSA?
There's nothing in the Affordable Care Act.
There's not. What about the medical loss ratio? Are you going to count the amount of money that I contribute to my health savings account as a medical expense, or is that an administrative expense?
Well, at this point, I don't think it counts in the MLR provisions, but we are looking at HSAs and HRAs in connection with...
Can you guarantee me that I will be able to keep my HSA when this thing is fully implemented?
I don't see any reason why you couldn't keep your HSA.
Well, I will tell you my read of that there is a risk. And if we really want to control costs without rationing, and I do, because I don't like rationing, but if we really want to control costs, we will leave the healthcare consumer, the patient, in charge of a lot of the decisions and the money of their expenditures. Because I know from my own experience, I'm a much more cost-conscious shopper in healthcare because it's my money that I'm spending, money being designated from my health savings account. President Obama himself in the East Room of the White House told us this last year when he had us all down there to talk to us about the debt limit. He referenced how expensive healthcare was, and He said he got a rash on his back. He put some cream on it. It was a $5 copay, but he was out on the campaign trail. He didn't have his card, and he went to the pharmacist to explain the predicament. The pharmacist got the prescription transferred. Thank you, electronic health records. But when the prescription was boxed up and handed to him, he was told that it'd be $400. And the president said, you know, this rash is not that bad. And exactly right, Mr. President. You became an informed healthcare consumer. So the power of putting this power in the hands of the consumer really can be a powerful incentive to hold costs down. And the only other thing you've got, the only other lever you can pull is you say we're going to have waiting lists or rationing, or we're going to cut reimbursements to physicians. We saw what happened in Medicare with the SGR. You cut my reimbursement, my fixed costs remain the same, so what do? I do more stuff. So I cost you more money because I've still got to pay the same bills that I had to pay before. So I really think getting away from an HSA type model, especially for people who are in the immediate pre-Medicare years, that's going to be a big mistake, and it's going to drive costs up, not the other way around. Now, having been in practice and having seen what happened when an insurance company went bankrupt, and seeing the effect on patients and the people who are supposed to be paid by all those claims that didn't get paid, and yeah, there was a small state fund that we could go to, but no way near covered the expenses. Are you concerned at all that when a company comes to you and says, we need to raise our rate, and it's based on actuarial evidence, are you concerned at all when you hold these rates down that you may be driving companies toward insolvency, maybe not tomorrow, maybe not next year, but over time?
Well, first of all, HHS, when we review rates in the small number of states that we do it, we don't have the ability or the authority under the ACA to actually force the company to do anything different. We make a conclusion, and the company can proceed if they want to with the rate. And certainly in the states that do have the authority to modify rates, it's something that they and I did this as well, you need to take into account when you're looking at their rate filings.
Wait a minute. I thought under the Affordable Care Act, rates are going to go down because you're going to prevent large increases from the insurance companies. Did I not hear that said several times this morning?
And I think the evidence shows that that is happening. I think all I'm saying is that when regulators look at the rates, they have to make sure they're reasonable and not excessive. And you're absolutely right. They have to make sure they're not inadequate as well,
so a
that
recent
the
news
companies
story
have enough revenue.
Said rates went up 26% in Alaska, 23% in Florida, 20% in Washington State, all since the implementation of the Affordable Care Act. Is that going to be modified in the future, or are those rates going to be going up less because of the Affordable Care Act?
I'm not sure what you're citing there.
Well, it was an article in the general news. Mr. Chairman, I'll yield back at this point, but I'm going to submit that question with more detail, and I would appreciate a thoughtful answer to that.
Okay.
All right. The gentleman, time has expired. The gentleman from Virginia is recognized for 5 minutes.
Thank you, Mr. Chairman. Let's talk about medical loss ratio rebates. Your testimony states consumers will receive a notice explaining their carrier's medical loss ratio, MLR, if their carrier owes them a rebate on their premium payments. Now, as I understand it, this is to be issued in August of 2012. Is that correct?
That's right. If rebates are repaid, they would come out. They're supposed to be done by August.
By August of 2012.
Mm-hmm.
And the law requires the companies to send these notices out or the rebates out?
Yes. I mean, we proposed in our regulations that when an individual gets a rebate, that they would get a notice from their insurance company describing what it is they're getting and whether their company complied with the law and what the MLR was.
Let me ask this question. Does the carrier have to send all of their customers a letter whether or not they get a rebate, or only if they get a rebate?
Well, two things. One, in the rule that's on the books now, we, from the beginning, have made it clear that when there is a rebate to be provided, yeah, the consumer would get a notice. We did propose for consideration and posted the idea that for consumers whose company complied with the MLR requirements but didn't get a rebate, that they would get a notice so the company would the consumer would understand that their company complied with the law and they got value for their insurance premium. So that's a proposal that we've made, and we haven't finalized that idea yet.
So if that proposal were to be finalized, everybody would receive a letter in August 2012 talking about either rebates or we complied with the law in regard to this section right before the election, but all the costs under the bill to the hardworking American taxpayers occur after the election. Isn't that correct?
Well, the timing,
you didn't fix the timing. I understand
and
that.
it doesn't have anything to do with the
But
election.
it is an accurate statement, is it not, sir?
It is accurate.
Thank
that
you very
August
much.
is before
I yield to
November.
Dr. Burgess.
Just one last series of questions on the budget, and going back to Section 1311A on the authority that you have, CISIO has, to draw funds from the Treasury and administer grants to the states and territories to establish exchanges. The end of November 2011, I think you told us $733 million was obligated to the states and $27 million had actually been spent. Does that sound about right?
Yes.
So that was November. You may not have it right in front of you, but can you provide to the committee what has gone out to the states since November?
Yeah, we had another round of establishment grants, so I think the total grants, including everything, innovation grants, planning grants, establishment grants, I think is up to $800 or $900 million. The rate at which states are drawing down on that money continues to lag behind the grants that we make, as they go out and they do a procurement to hire outside experts and IT consultants, and then the procurement has to come on board, and then the agency has to bill. So there's a lag between the obligations and the outlays for those state grants.
Well, the previous projections estimated a total of $2 billion would be spent in the exchange grants over the life of the program. When do you expect this money will be fully exhausted?
Well, unlike the $1 billion, the money that's available to provide grants to states is not limited. It's from a separate funding source.
So you got a new projection for us on what the draw
On
of the
how
Treasury?
much states ultimately will spend? We don't. I mean, we're getting better insight to that as states come in with their grant applications and tell us what they think it's going to cost to build an exchange in their state. So
Let me just ask you something. There are a lot of things that the last Congress and this Congress has done to sort of kick cans down various roads. And it looks to me that all roads end in December of this year. In December of this year.
December of this year?
Yeah. Well, the doc fix, the unemployment insurance expiration, the unemployment insurance, payroll tax holiday, Bush-Obama tax cuts. A lot of things expire at the end of this year. Of course, the alternative minimum tax always expires at the end of every year. So there's a lot of stuff that's going to happen at the end of this year. It's quite possible we will be at or near exceeding the statutory debt limit of the United States of America by that time as well. It is difficult as increasing the debt limit was in August of last year. This time it will be without all the good feelings that we had last August. Do you worry at all that the subsidies in the exchange, which Mr. Griffin has already talked about, are you concerned that that may have to be postponed simply because we're out of money and cannot afford it?
Well, I certainly hope not, and hope that everyone will come together to make sure that that doesn't happen, because they're an important part of expanding the coverage provisions in the ACA.
Even if we're borrowing in excess of 40% of those dollars that we're going to be handing out to people to subsidize their insurance?
We just we hope it doesn't happen, because it's such an important part of the Affordable Care Act.
There's no place else to go for another sequester other than the Affordable Care Act. It has been remarkably protected. It has led a charmed life with all the other budget-cutting things that are going on. I got to believe at some point that charmed life expires. Thank you, Mr. Chairman. You've been generous. I'll yield back.
I thank the gentleman. And at this, we're all finished with our hearing. Does the Chairman Emeritus have any closing comments before I close the committee?
Just to thank you, Mr. Chairman, and to thank our witness. Mr. Larson, you've done a superb job.
Thank you.
I think it's been a very useful and very helpful hearing, Mr. Chairman, and I commend you for it.
All right, thank you.
And I think that we have laid to rest a lot of the concerns that I've heard expressed, and we've been able to observe that some of the concerns I've heard have been essentially red herrings drawn diligently across the pathway of success in the future. I want to thank you for your fine participation in this, Mr. Chairman, and you, Mr. Larson, thank you for your kindness. To my colleagues here, I want to say we appreciate your getting these questions out, because they are valuable and they will lead us to a better understanding of the events before us in this legislation. Thank you all, Mr.
And
Chairman.
with that, I would agree that this hearing will give us a better understanding of Obamacare. I want to thank the witness for coming today and for the testimony and members for their devotion to this hearing today. The committee rules provide that members have 10 days to submit additional questions for the record to the witness. With that, the subcommittee is adjourned.